Okay. Good evening. My name is Bob Tajan. I am one of the co-chair for the ASCS Research Committee. Along with the chair of the committee, Ty Lee, would like to welcome everyone tonight that's come to join us for the first of our ASCS research webinars. We've created a series as part of an educational experience that the committee has put together to hopefully highlight some of the topics with regards to shoulder and elbow research. This is the first webinar of a three-part series, and tonight's topic is going to be on improving clinical research in shoulder and elbow surgery. And we're very honored to have three separate guests who have tremendous amount of experience in these separate areas. So the format tonight, it's going to be 3 10-minute talks followed by about a 30-minute discussion. And if you have questions, please put them into chat and we'll be able to address those. We won't probably do it during the talks, but we'll get to all of them during the discussion section. The three surgeons who will give us talks tonight are well known by most of you. So Dr. John Levy's from Holy Cross Hospital down in Florida. He'll be discussing how to initiate and perform clinical research in private practice. John's done an amazing job himself at producing high-level research in a private practice environment. Dr. Peter Lappner from our friends to the north, he is going to discuss how to successfully perform randomized clinical trials. Peter's done an amazing job at doing exactly this with regards to rotator cuff instability, arthroplasty, with multiple successful trials. So I think we'll hopefully hear some pearls of wisdom that he'll give us on how to complete these studies. And then last but not least, Dr. Joe Iannotti from the Cleveland Clinic. He'll be discussing how to successfully fund clinical research. And again, Dr. Iannotti's had a large experience with funding both basic and clinical science, and we hope that he'll share some strategies with us. The other two webinars that are planned for the rest of the year, we have one in June on improving basic science research in shoulder and elbow surgery with Dr. Scott Rodeo, Mark Frankel, and James Johnson. And then we have a webinar in October specifically looking at multi-center studies, and Jed Kuhn, Eric Ricchetti, and Andy Jawa will be talking about their extensive experience on these topics. And with that, I will transition it over to Dr. Levy, and he will start us off.
Thanks, Bob. I'm going to pull up my slide deck here. I appreciate the invite and the opportunity to share my experience. So you've tasked me with the topic of how to initiate and perform clinical research in a private practice model. And kind of to start, for those of you who don't know who I am, I'm stationed here in Holy Cross Hospital. It's the first job I've ever had. But my background really was I started out, I grew up in South Florida, so coming back home was a no-brainer to me. I trained at University of Miami, the Jackson Memorial Hospital residency, where it was really hard to do research because it was a public hospital. And I literally had to go down into the bowels of the archives to try to look through charts that would never complete. It was very frustrating. And then I did a fellowship with Mark Frankel, where I really saw the opposite. I saw how to run a very successful basic science and clinical research. And it kind of set the stage for things that I would do in the future. And I settled in at Holy Cross Hospital, where I've been employed since 2006 as an employed physician. I did spend some time at Mayo Clinic, where I saw how their research department kind of runs. And I think you kind of take bits and pieces as you develop your own model. And what I'm going to share with you guys is really kind of what worked for me. It's just a model that worked, and it was successful in private practice, just to kind of show you that this stuff can happen. And it can be actually, in my opinion, maybe even more successful and easier to do than in a true university-based academic center. But it starts with a commitment. You got to commit to research early. And so, yeah, I did it in residency, but I already told you, it was really hard to do research when I was in residency. We just didn't have the resources. We had a small, minimal commitment at the time to doing research. So it was hard to do, but in fellowship, it was easy to do. And so I really kind of focused on really a commitment to clinical research then. And then when you start in practice, once you take off and you set up the infrastructure, things can crank. And that's been my experience, but it doesn't happen on its own. And it's really all about kind of how do you build your team? You have to have your own persistence and dedication. You have to have consistency with all parts of the process, from the minute the patient walks in that you think might be a candidate for surgery, or you might want to study that, all the way through making sure that patients don't leave the office until they've completed their patient-reported outcome measures. Tons of partnerships. The partnerships that I have with the hospital have been phenomenal. It's really what was my sort of secret sauce. And developing the team, it's all about the team. And unless you develop a quality team, I don't care where you are, you can't do this on your own. So when I started practice, I really said, okay, this is my commitment. I want to start by collecting patient-reported outcome measures. And I use my extra time in order to work on the workflow. And that's really important, because if you don't have your own research department and you're going to do it on your own in private practice, you have to make sure everybody else knows around you that it's important to you. So your patients should, at every pre-op visit, and I have a dedicated pre-op visit. We do a lot during that pre-op visit, but one of the things we do is go through baseline patient-reported outcome measures. If they're in trials, we make sure that that's where the research team comes in and does informed consent and make sure everything's done up front. And then you just have to educate your staff, and the staff has to be on board. Everybody on my team knows that if a patient is here for a post-op visit, it's important. They have complete questionnaires and they get a tablet nowadays. Back in the early days, I did it like this, which is what I did on paper. And wow, it seems archaic, because I can't imagine that people are still doing this anymore. But we did it, and I did it for many years, and it was tedious and often incomplete. We actually went back and studied, probably about half the surveys were incomplete. Patients would get survey fatigue, and they just sort of like just check box everywhere and not really be honest with the results. And at the time, we didn't have a formal database. And you know, in my early years, private practice research was collaborative research. I collaborated with my fellowship. It was really easy to do. I would call in Dr. Frankel's bi-monthly meetings. I did remote research as much as I could. And then I started to do some more independent stuff. But when you first start, you can't do big studies. You do case reports and surgical techniques and review articles. And those are the things that build, that are easy to build on, because they don't require long-term follow-up. Because if you're waiting for long-term follow-up, you're going to be years into practice before you can have enough patients to actually do a study. You need that patient volume. In 2010, this is a big game-changing moment for me. I sat down with my CEO and I said, listen, research is really important to me, and I think we need a little bit more infrastructure. Right now, I've been trying to kind of do it myself. I have my PA that do it, but she's not that interested in it. I need someone who's going to be committed, and I want to do this right. And so I created a business plan, and I presented it to my CEO. And we were lucky enough that about a year before, we had our institution had a major donor in the cardiovascular research. They had a $20 million donor, and it was a match donor. If the hospital could raise, let's say 10, I think they matched 20. It was really a big number. And so our CEO bought in right away, and they said, okay, this could be an opportunity to be a really big fundraising opportunity for our hospital. And so there was literally no hesitation. Once I presented a business plan, I had a mission and a vision and figured out how much it would cost, what the basic cost would be. He bought in. And so by November that year, we had launched the Orthopedic Research Institute. We had the hospital supported a research director on office space. We had one full-time employee and the office space. And then we started doing a lot more work, because I had personnel and committed people to do research. It was easier to do stuff. We still did the same case reports and surgical techniques, but we started to really build our database and build what would eventually become multi-center studies and a lot more of what I would call better quality research. And the next big game changer happened when we transitioned to a tablet form. So in 2012, we made the decision, after interviewing several different database companies, to sign up with MedTrack. They have a CareSense database. I then had to put all the old paper databases into our CareSense database, and we went live in October of that year. And now the workflow became a little bit easier, because now everything was on iPad. So patients were able to actually sit with an iPad and not, our ability to get complete surveys actually went up. We were able to make sure that patients can't go to the next screen until they finish all their questions. And I'd say this is now the standard of care, so to speak, for research. There's about a half dozen different companies that can do this, with two that I think are sponsored by the ASES, to make it easier for private practice research to take place. But it's still, you have to be committed to the workflow. So the culture of the office has to remind patients to complete their forms. And most database companies will have email reminders that will give them a web link or something. If they miss an appointment, there's a reminder, to capture it. We actually studied it. It actually improved our overall collection. And so these tablet-based database ensure not only that the workflow is simple, but you get complete data. And then you can improve the overall return rate, making sure that you can capture patient visits that may not have made it back to the office. When you're doing private practice modeling, you can't do, sometimes you don't have a mechanical testing lab in your office, so you have to collaborate. And so you can certainly apply for research grants like we did and do collaborative work like we did with 4 at the time. But a lot of the major cities will have a location or a university that has a biomechanics lab. So if you want to do biomechanics lab in addition to clinical research, that opportunity is available to you as well. But probably the biggest next jump that I saw in the way that we developed our research department was taking advantage of those that really want to do research. Volunteer research staff, those that have a real strong interest in orthopedics, they're med students, they're residents, taking advantage of those opportunities and guide them, hold their hand through the research process. And then expanding your on-staff research staff. As we get more funded projects and you have more financial support, it's easier to hire full-time employees. And the thing that we do every year, in addition to having my shoulder and elbow clinical fellow, we actually have a clinical research fellow, which is a funded research fellowship where you spend a year doing research. A lot of people are taking gap years as they're trying to build up their resume for orthopedics or trying to get into medical school or residency. And I think those are phenomenally motivated individuals. I've been lucky enough and fortunate enough to have had a series of really phenomenal research fellows, and it's amazing to see how they've now blossomed. Many have actually stayed into shoulder and elbow surgery. So this is the team that we've now assembled, and it's taken years to do it. Paul Papagni, he recently left. We are in the process of refilling the executive director of research, who's really in charge of research for our entire hospital, our cardiovascular, our oncology, and neurosciences, and us. But then as it gets closer to home, our clinical research coordinators, we have 2. We have a current research fellow. We have one for shoulder and elbow, one for hip and knee. And then we have a volunteer network. Right now we have 2 dedicated volunteers who've gone through the volunteer process through the hospital to become a hospital volunteer. And then they become part of our research team a little bit more on a part-time basis. And once you get that team right, now sky is the limit. And you can start to be doing such high quality research that you get involved in FDA trials, in addition to the industry sponsored trials, because you're showing your track record and they recognize that you can do super high quality research. We actually even had an FDA visit, on a random visit in one of our FDA trials. We all kind of held our breath for a week, but we had one of the easiest reviews that we've ever had. And literally to see that high quality of research being done at a private institution, it was almost surprising to the FDA as much as it was to us that it went so well. A lot of what we do is investigator-driven studies. And I think one of the biggest challenges in private practice research is sort of maintaining the ability to do investigator-driven studies, which are the typical studies that I do, prospective or retrospective clinical studies, but still being able to fund your research. And I know we'll hear some talks about how to get funding, but it is a little bit of a challenge because most major clinical research departments in cardiology and oncology, they have major clinical trials that fund their research. In orthopedics, that can be harder to find. So it is a bit of a challenge to try to make sure that you can do all of these things and not just focus on these sort of industry studies or the FDA trials, but really maintain that commitment to investigator-driven studies. So if I kind of have to summarize, what are the keys to developing research in a private practice model? You got to start early, commit early, collect data immediately and create that culture. Collaborate with your former fellowships or your local universities, local biomechanics labs, mechanics labs. Develop partners. The partnership that I have with my hospital has been phenomenal, and it's been a maintained commitment to research. Your CEOs just may not understand it, so it's up to you to tell them how important it is and what the opportunities will be for the hospital. And cultivate that sort of drive and enthusiasm for research. Surround yourself with really smart and motivated people, and you'll find them in medical school and in residency, and those that really want to join our field and become part of our family. Utilize volunteers and to really help promote their career as you really develop this big research team. And I think of this as, all my fellows are my family, both my clinical fellows and my research fellows, and it's great to see how they progress during their careers. And I think this is, one model. It's worked for us. It's replicatable. It's something you can do. And I do think the ability to be successful in the private practice model, I would argue it may be actually easier than the university setting. So thanks, Bob. It was a great opportunity to be here. So thanks.
Thanks, John. Really amazing. And I think it, this really gives a kind of a blueprint for people that really want to go out and kind of do impactful research, but aren't necessarily inside a university setting and might say, okay, how do I start and where do we go? And I got a lot of questions for you, but we'll hold those until the end. And so next, Peter is going to jump on, and he's going to load up his talk, and he's going to talk about randomized clinical trials. And Peter,
okay, thanks so much, Bob. Yeah.
No problem.
Okay, great. So yeah, so the topic here, so how to perform a randomized control trial. So to begin, I'll spend the first few minutes just discussing some of the main design elements with randomized control trials. And from there, we'll go on to discuss some of the benefits of running a pilot study. And I imagine that's all the time that we'll have. So I think in terms of some of the more practical tips, in terms of what I've learned over the last few years of running these sorts of trials, we may just push that to the discussion. We'll see how that goes. So the purpose of any clinical investigation is to study the etiology of disease. We can look at disease prevalence in a population. We can look at the natural history. We can develop information to lay the foundation for public policy. But as surgeon investigators and surgeon scientists, we're sometimes most interested in looking at investigating therapeutic measures and new treatments. So this brings us to the fundamental design of the experimental study, which is a study in which the investigator intervenes in the natural history of a condition. And this is what makes RCT so unique and so different from observational studies, in that in the randomized trial, because we control that variable, we can then infer that any change in outcome relates back to that one variable that we control. So what that means is that the RCT is the only study design that allows us to prove cause and effect. And that's very powerful. And that's again what makes it so different from observational studies, where we look at a data set and we can make observations in populations, and from there we can make an inference to show an association, but you can never prove cause and effect with an observational study. So experimental trial design, interestingly, it goes all the way back to the time of the Bible. This was a write-up this was a description: prove thy servants, I beseech thee, 10 days. So this was an experiment that was described. It was a 10-day study. They described, there was two groups of kids, and one was fed a vegetarian diet. They described that as pulse. And then another group of children was described as eating the king's meat. So they fed them meat. There was even a mention of informed consent. And at the end of the 10 days, they looked at the countenances. So they looked at how these kids looked after eating either the meat or the vegetarian diet. So I thought this was quite interesting. So, and that really lays the basic foundation for how these trials are designed. It's exactly that. We define the population, we separate them into two groups. We look at the two groups, and then we determine how much they improve or how much they don't improve. And then we compare the two groups in terms of the final outcomes. So we can look at therapy versus no therapy, or you can look at a new treatment compared to an established treatment whose benefits are known. So if we break this down and we look at some of the fundamental design elements of RCTs, and there are 5 or 6 of them that I think are worth touching on if people are thinking about embarking on this. The first is the selection of subjects. And this is a bit of a balancing act, because if the inclusion criteria are too narrow, the risk is that the results may not be generalizable. On the other hand, if the inclusion criteria are too broad, then you risk losing the treatment effect. So that can be another issue. So you have to think about that carefully. So next, we allocate the participants into groups. And the key here, so there are alternatives to randomized trials. So, I mean, we can look at case reports or case series, which are options without a comparator, or we can look at groups with a comparison, and there's different options. We can look at historical controls, or you can look at a similar group of participants that were selected in a non-randomized fashion. But the shortcoming to that approach is that, and this is a study that was in the published literature. So this was a study that looked at lesser tuberosity osteotomy in comparison to a subscapular sternotomy and anatomic shoulder arthroplasty. And what the study found was that the functional scores were higher in the osteotomy group compared with the sternotomy group, and that was a statistically significant finding. And shortly after that, a randomized trial was published on the same subject, LTO versus sternotomy. This was random allocation, and interestingly, this study found that the functional scores were almost identical. So this is often what we find. So observational studies have a tendency to exaggerate the treatment effect, and this is due to the effect of selection bias. So again, so the whole issue here is that if the allocation of the subject to the treatment groups is predictable, then we risk falling into this trap. And this is the main purpose of randomization, which is preventing selection bias by avoiding predictability. So it's allocating subjects and groups in a fashion that's completely unpredictable. And the byproduct of that is that it tends to, over time, increase the likelihood that the two groups are similar at baseline. But it doesn't guarantee that they're similar at baseline. This was a randomized trial that we published a number of years ago looking at lesser tuberosity osteotomy versus Peel. And you can see that one of the reviewers flagged this issue that the two groups were, although they were somewhat similar, there was a 5-year span in age. And when we looked at this, there was actually a statistical difference. We ended up having to control for this after the fact during the analysis. So it doesn't guarantee that the two groups will be identical at baseline. So this brings us to the next strategy, which is stratification. So stratification is a strategy that we can use to either guarantee or have a very, very high likelihood that the two groups are very similar at baseline. And so this was a study of 1,000 patients, just by way of example, to show how this works. So you can stratify by multiple variables. First, in this example, stratifying by gender, and then stratifying by age. And then subsequent to that, we carry out the randomization. And as I said, this guarantees that the two groups in this example will be almost identical or identical in terms of age and gender. So next we come to data collection. So it's important to report on the treatment assigned as opposed to the treatment received. So this is the intention to treat principle. And the basic premise here is that if you don't do this, if you don't abide by the intention to treat principle, then you begin to lose some of the benefits of randomization and you introduce the potential for bias. The other secondary issue is that it gives you a much more accurate real-world representation of what the true treatment effect is, taking compliance and other issues like adverse events into account. Next is the issue of outcome reporting. So it's important to report not only the beneficial outcomes of the treatment, but also complications and adverse events. And the third issue has to do with the prognostic profile at entry. So what that refers to is the demographics. So when we report the demographic information, it's important to not simply describe the participants at baseline in terms of general demographic terms, but to think about describing them in terms of the main prognostic factors at the beginning of the trial so that the reader or the investigator can assure themselves that the two groups were indeed similar at the beginning of the trial in terms of the main prognostic factors. Next comes the issue of masking or blinding. So this can be done on 3 different levels: at the subject level, the data collector in terms of data collection, and finally at the analysis level. This was an example of a study that was published a number of years ago in 1975. This was a randomized controlled trial looking at the effects of vitamin C versus placebo in a group of participants, and they were interested in seeing whether vitamin C had any beneficial effect into the number or the severity of colds that these participants had over a 12-month period. And there was, in fact, a moderate treatment effect. So there was a benefit to vitamin C. But what was interesting was that the investigators didn't realize this initially, but they later discovered that the participants had were able to guess, they were able to identify what they were receiving by the taste. And when they went back and they analyzed the results, they found that when they analyzed them according to what the participants thought that they received, there was actually no treatment benefit whatsoever of vitamin C versus placebo. So this really illustrates the power of placebo and the importance of maintaining the blind. So this is, and this is also very important in surgical trials, by the way, especially in this era of how patients have ready access to their medical records. So it's important to check that box so that the operative report or the follow-up notes that might identify which group they're assigned to don't end up in the MyChart or whatever the equivalent might be in your EMR. So finally, there's the issue of compliance. The willingness of participants to carry out the study protocols. And, you know, this is really, I think, first and foremost, an issue with pharmaceutical trials, but it also can be an issue in surgical trials. So it's something to keep in mind, especially in terms of the non-operative elements of the studies that we carry out. So those are the main design elements that I wanted to discuss. So from here, we move on to the benefits of a pilot study. So a pilot study is a small experiment that we run as a preliminary dress rehearsal before embarking on a full-scale trial. And it usually involves about 10 to 20% of the sample size, but there are a lot of very significant benefits to doing this. Because there tends to be a limited amount of variation within the data, it usually is not appropriate to use this data for the purpose of a sample size calculation. But what it does do, is that it allows the investigator to test the consent forms, the case report forms, the randomization procedure. It allows you to make sure that you have the right outcome measures that you're looking at, that your technicians are appropriately trained, the equipment works. And it even lets you look at the reliability and the validity of the results. And in some instances, it might even allow you to identify early adverse events or complications. So given how competitive it is, and I think that we will hear about applying for grants a little bit later on this hour, this often becomes a prerequisite for funding. So given the limited, the sparse allocation for MSK research funding, sometimes this makes the difference between successful grants and not successful grants in terms of being able to provide pilot data to prove you can carry out the study. Summary statistics are usually only reasonable in this situation, but if the methodology doesn't change significantly, it's not crazy to roll the pilot patients into your main study. And also keep in mind that this data is often publishable in its own right. So those are the main things. I did have a few other ideas in just more on the more practical side, but I'm sure that'll come up in the discussion. So Bob, I'll give it back to you. Thank you.
Great. Peter, really amazing. And I think that from someone that's obviously done this several times, it is, you know, there is a large hurdle to getting over, you know, to starting this type of work. And I think we'll dig into a couple questions, at least that I have, that will be able to kind of address some of those issues. And last, again, like to welcome Dr. Iannotti here. I'm glad that we were able to overcome whatever technical issues that we have. He has been kind enough to be able to talk about getting successfully funded in clinical research. So Joe, I don't know if you can pull up your slides on your side. Yep, it's great. It's coming through and we see them.
Great, thank you. Can you hear me now? Can you hear me?
We can.
Okay,
Yep,
great.
Perfect.
I see
Thank
a
you.
thumb up. So I sort of took a little different approach, which may not have hit the target for what the group wanted. So I'll go through what I put together, and then we can maybe regroup and talk a little bit about how to write a grant, but probably need more than 10 minutes. But here we go. So again, observation, if you look at the clinical literature for clinical research, most studies that are published don't report or indicate any source of extramural funding. And this goes along a lot with what Jonathan Levy talked about, and he's been a very, very successful clinician scholar and has written a tremendous amount of work. And they generally are level 3 or 4 studies, and they really relate to the clinical practice, as he said, either prospective data collection or retrospective data analysis. And often it is really utilization of fellows and residents, and they could be residents or even research trainees. And as a result of that type of building infrastructure within the normal clinical flow of your practice, assuming you do this, in a prospective way, and you link it sometimes to the EMR for additional data, you really are subsidizing the research you're doing, both directly and indirectly through clinical operations. Now, some groups, many groups, do that through their own personal clinical care, clinical revenue. Others, as Jonathan did, and many will, make a formal arrangement with a hospital that is very motivated to continue to grow the practice and to build a brand and to get some recognition as a center of excellence, will help subsidize that, either through paying for the fellows or actually paying for the data collection and the data analytics. And I would say probably, again, you can ask the people on this webinar, I would guess 75–80% of what's published and of value to all of us, it comes through this mechanism. If we look at the sources of funding, as I said, most of this comes through clinical operations. Some of us are fortunate in that we take care of people that are very grateful and sometimes live in environments much like Southeast Florida, where there's a very dense population of people and a lot of wealthy people. And some of those are interested in orthopedics or musculoskeletal care and research. So again, that's sometimes an avenue. It's usually not enough on a consistent basis to necessarily fund as an endowment large research programs. Industry, certainly there are some opportunities in an industry, particularly if it's product driven or device driven, but again, you got to be careful in terms of conflict of interest issues. And there's often ties and restrictions in terms of the data, the use of the data, and sometimes you can't ask questions you really prefer to ask, but are sort of somewhat restricted by the nature of where the funds come from. Obviously, societies and foundations, much like ASES, they do provide limited funding for short periods of time. So again, it's difficult to build research programs, but it's a good way to start. It's, if you've got a well-written proposal and a good idea, and you're working in a good environment, meaning that the review committee says there's mentors and others that will help you develop as a clinician scholar, then these dollars do help. Obviously, most of us are looking for federal or peer-reviewed state or federal funding. These are usually much larger dollars. Typical R01 is somewhere between $250,000 to $500,000 a year, and typically for a 5-year period. But again, they're very competitive, and our experience has been that in most cases, the NIH and NIAMS is not keenly interested in funding the type of research that often we're interested in doing, which, even if it's hypothesis driven and a randomized study, often those dollars are very limited. It's mostly going to basic science research and mechanistic type research. I think one of the things that is important to do is to sort of take a hard look at what your program offers, because what your research program offers often leads you to understand where the funds most likely lie. Now, most successful research programs are multidisciplinary. There are multiple people involved. There are clinicians, clinician scientists. There are basic scientists, imaging colleagues, and each of those people have a certain niche or areas for research. And when you do have multidisciplinary research, sometimes your most successful funding is through, multiple sources of funding. And it may be that some of the funding comes from an orthopedic society, and some of it comes from NIH, and some of it comes from industry. And when you cobble it all together, you can often cover not just high quality research over a long period of time, but sometimes when funding dries up in one source, you actually have dollars either from endowment or philanthropy or industry that sometimes keeps the team together, while you might get funding from a source that is typically difficult, like peer review federal funding. So the point of this slide is understand your value proposition. So if you're advancing science, you're really trying to answer very fundamental questions in a prospective way. And you're trying to either develop new technology or new knowledge. Really, you're looking at peer review grants in order to try to do that, because these are multiple years of funding year over year. It's usually fairly expensive. It's usually multidisciplinary. And so you have to define if that's really where you're going. Obviously, if you have an opportunity for intellectual property, then you can sometimes get investment related funding. So for example, I applied for state of Ohio funding. We got about $7.5 million over the course of about 3 years, and it was to develop 3D software planning and patient-specific instruments. And obviously that was very successful. That was probably 15 or 16 years ago. So it was very early in the evolution of preoperative planning. But we developed the program so that the money was used not just to develop technology, but it was to study implant survival and factors that are associated with implant loosening. And that same $7 million has continued to fund clinical investigation and prospective study that has yielded a couple of NIH grants. So again, that's understanding the value proposition. What are you doing, and how can you take money from one value proposition and potentially using it for the other, meaning advancing science. If you're supporting a product or a technology, particularly if it's already FDA approved, this is kind of where industry likes to fund clinical researchers because post-market validation of whatever that is, if it's an anchor or if it's a graft or if it's an implant, prosthetic implant, if you can get through the conflict of interest issues, then sometimes this is a good source. It could be related to education and training. And again, this is where clinical operations supports trainees, and most trainees, to get ACGME accreditation, there has to be some scholarly activity. So your institution may help support that. And the area that we've explored a lot, and again, I think this is again where Jonathan Levy talked about this, is, how do you brand your product line? How do you define outcomes, the cost of care, what's your brand, what value does your practice bring to the community that defines you as a center of excellence? And this is where hospital clinical operations, if you fashion it as a program and not a project, and data is collected not just for research, but sometimes for cost effectiveness analysis, supply chain issues, that data has high value to the organization. Now, you got to convince the executive team that their investment in research that you want to do has value to them. And sometimes they get it quite easily, and other times they're not as progressive in their thinking. But the trend towards value-based care and pay-for-performance payments, although we are still measuring process measures like readmissions and infection rates, you know, the reality is that at some point, they're going to try to have assessment of the quality of care and the patient outcome rather than just the processes of care. So I already alluded to this in terms of, you know, defining your research program versus a project. So projects are relatively easy to fund, especially if they're retrospective. It's clinical research. They're usually relatively low cost. The clinical data is probably already available, and you're really trying to curate the data, analyze it, and put it into some kind of publishable form. Programs, on the other hand, where you say, I envision multiple questions that are going to take 4, 5, 10 years to answer. Those are the ones that require programmatic funding over a sustained period of time. And we talked about that. We also talked a little bit about the team in terms of the sources of training, sources of funding associated with the people on the team. So when you got multidisciplinary members of the team, then each of them, assuming that they're fully vested and invested in the program, have some responsibility for helping to get funding for the work. I guess the last thing to talk about maybe is not so much funding related, but it is in some measure, because a lot of people have great questions. Unfortunately, the process is doomed to fail before this research actually starts, because you don't take a hard look on the capabilities of the team and the feasibility of doing it with the data you either have or you're going to collect. And this may relate to technology, it may relate to patient population, it may relate to systems within your health system. So for example, if you've got a study where you're looking for biomarkers in patients and your path lab can't do the analysis, then you know you may want to choose a different area to investigate, or you're going to have to go to the path department and say, how do we develop the technology in order to do that particular study? The last part, which again is a area where some people fall short, is to be sure you have a realistic budget, both in terms of the direct and indirect costs. And this is true for industry funding or related to a clinical trial. There are a lot of clinical trials that you might take on, and for you to break even on the budget, you've got to enroll 20 patients a year, and the people you hire to do that work and you're paying their salary is the same if you enroll 10 or you enroll 20. And if your budget called for enrolling 20 and you only enroll 10, then the cash you get in the door for entering those patients is half of what you budgeted for. So either you or the department or some fund basically paid for half of the cost for that year based on insufficient enrollment. So again, there are many, many ways to go afoul, even when it's industry funding and they're paying you what seems like a lot of money per patient for completion of the study. You've got to be sure that you've got the feasibility and the capability of enrolling patients in that study. So that's all I really have. Again, it's more of sort of the do's and don'ts more than saying, well, how do I write a grant for a successful peer review, which is probably a little longer than 10 minutes.
Thanks, Joe. That was perfect. That was exactly what I had hoped that you would do. Obviously, yeah, a whole grant writing program, that's, you can take a 8-week course of an hour, each week to be able to go through how to write an R01 And obviously that kind of wasn't our mission here, but exactly outlining kind of a strategy with regards to on a 10,000 foot overview of things to get started on getting funding at the same time, maybe things to help avoid problems or pitfalls. I'll start with some questions, and I guess I'll start with Joe. And it kind of leads into John's talk, that it seems like probably for a private practice surgeon that's in practice, that the biggest bang for your buck is to really create a program, kind of like what John has done. And all the other ways to be able to get funding, you can get small pieces of funding, but really that's probably I think he's done it the best way to be able to do it. On the other side, for like as a message to junior faculty that might be on or might be listening, what do you think is the best way that a junior faculty at a teaching program can create a research program? Like, what's the best starting step for that faculty?
Well, I think the most successful ingredient is the person's passion and persistence. You've got to be 100% committed that regardless of the obstacles or what it's going to take, you're going to do systematic clinical data collection. Most of the cost is pretty modest, and it's the sweat equity, it's the time and effort. And, if you're in an environment where you're in a department where this is the culture and there's infrastructure already there in, say, another group, say, the hip and knee arthroplasty group, and they've got a database collection, they've got analysts, they've got people collecting follow-up data, then that's the easiest, lowest bar. Because you say, well, shoulders are not that much different than hips and knees, different questions, but the database and the whole infrastructure. And then you have to really stick to it. And you got to be able to, decide what not to collect more than what to collect.
Sure.
And then you go, if you're truly going to do this on clinical operations, I think the best advice I would give is really define the value proposition to the hospital and the organization. And that could be your department chair. It could be your hospital president or your CMO. Can you articulate why this is important to them? And
Sure.
Typically, at some point in time, it relates to contracting and money and reputation, branding, patient referrals. So there's a reason John does 350 shoulder arthroplasties a year. I mean, he is a good surgeon and he lives in Broward County, but he's well known for the work that he's done year over year. So it takes a lot of sweat equity. And, and I think there's a lot of kudos to be given to somebody who does that versus somebody who's in a lab and, every resource in the world is there.
Sure.
They don't have to build much of anything.
Yeah, I agree. I think one of the take home from that is, I think in an academic department, junior faculty, you said it's focus. And so that I think the problem is that a lot of times that research becomes too diverse. You look at a little bit of something here and a little bit of something here and a little bit of something here. It's defining the area that you want to actually investigate and really put a lot of energy into that area. And I think that's how I agree, that's how you build steam in an academic department to be able to then get money to come in.
Hey, Bob, I think, Derek Cuff has done a variation of what you're just saying, and he's done it really well, right? Yeah. So Derek also is in a private practice community practice out in the West Coast of Florida. And he will sort of pick and choose specific projects that he wants to do. While I think in general, the bar has been lowered in terms of your ability to get started with research now that we have these mega database companies that allow it to be done in a relatively inexpensive way and collect data for everybody. But I think if you target, if you're just getting started and you target specific projects, and then you can do what Dr. and I were saying, you fund a project on a program. he's done that really, really successfully. And it takes a good scientist to recognize what those good projects are and really try to do some good quality ones. Yeah. Because what you think is good may not be what everybody thinks is a good project. Sure. But I think that's just another variation of what we were talking about. And he happens to have done it really well.
Yeah, and I think...
Bob, let me ask a question.
Sure.
I think it's clear for all of us who do research that we all have passion for this, and we'll get it done no matter what. I think one of the things that I'd like to get from the panel, both Peter, John, and Joe, is that maybe it's a fault of our education system, where how do we emphasize the importance of clinical data to residents, as well as fellows, as well as private practice guys. A lot of times I'll be talking to surgeons, they'll say, oh, I did this great thing and patient is great, doing great, and it really works. And I always tell them, if you don't write it up, when you die, it's gonna die with you. So,
or sooner.
But unfortunately, when I talk to these people, it's really hard to have them spend a little extra time collecting their clinical data and assess their own performance as well as teaching others. Do you have any advice for that? Because it's generally people who have it, and people who don't. And unfortunately, majority of them don't have it.
Todd, I think CMS is starting to change that, right? At some point, we're going to have to be collecting outcomes in order to get paid. I mean, that's the future. And so I think that will be the thing that makes everybody pay attention to it. It's starting to happen in little microcosms already. But you're right. I think to write is to educate, and you have to be committed to that education process. And yes, you have great ideas. There are some people who have great ideas that just don't know how to articulate it into a written form. And so sometimes that's a big challenge too. It's just the confidence of being able to write a paper, to be able to get it out in words. I think that, that's one of the things that when I'm working with research fellows, is a teaching process of how to write a paper. And you'd think you'd learn that in residency. And maybe now that research is it's way more prevalent in residency than it was when I was there. It may be happening more commonly, but I think that could be a big barrier too. Just teaching how to write.
One of my mentors told me that ideas are cheap. It's the data that's expensive. And expensive doesn't always mean money. Expensive could be your personal time and effort. And honestly, I think a lot of people who are really good surgeons and are smart and could do something just don't necessarily have the will or the ability. Sometimes it's family or other things in their life where they just can't create the bandwidth to do that extra work. I mean, when I interviewed at the Cleveland Clinic for a job, I asked the guy who was interviewing me, how much time do the staff get to do academic activities and research? He says, well, we give everybody 2 days a week. And that was Saturday and Sunday. So, you got to carve out time. And sometimes it causes you, other issues in terms of balancing life and family. And I mean, it's a sacrifice. And if it's a struggle to give that sacrifice, you just don't do it. If you love it and it's a passion and you're driven by it, then you figure out how to get it done.
I agree. Peter, I guess it would be interesting to hear your thoughts from from obviously a more socialized medicine standpoint with regards to if it's easier to have the students be attracted, or young surgeons attracted towards doing research, or maybe the opposite. And then I guess the other question that I had also was, from a trialing standpoint for you, kind of what do you think is your top hurdle that you had with trying to actually accomplish what you've done? Because I think it would be just good to hear, from a guy who's done a lot of really great studies, what would you say be the number one thing that's been the hardest thing for you?
Yeah, so those are great questions. And the first thing that you asked of Joe in terms of how does the new investigator really get off the ground, I thought he raised some great points there. For me, so when I first started, I think that it became very clear very quickly the importance that my mentors had over the course of my training. And, you know, we cultivate these relationships over the course of medical school and residency and fellowship. And then we get going and we meet people that are like-minded at meetings. And I think it's really important to continue to cultivate those relationships, because when it gets to, I mean, it's one thing to ask a colleague, how would you approach this clinical problem? But I think it's equally important to have strong research mentors to help us along the way, because as others have just alluded to, it's one thing to have a great idea, but it's a huge, I mean, let's face it, research it can be very challenging and there are many obstacles to it. So it really is helpful to have someone who's gone through the process many times to help. The other thing I think that really was important for me right at the outset was to sit down. So John mentioned writing a paper, and of course, that's a huge part of it. The other half is just sitting down and writing a grant. And sometimes, even if you're not successful, I mean, most university centers have local grants that we can apply to. You can start small, you can apply for a regional grant. And then once you get a bit of momentum, then you start to collect some data, then you have a little bit more under your belt and you're a little bit more competitive about going for some of the bigger and more competitive grants. But even if you're not successful initially, and I wasn't initially, the process is important because it really forces you to crystallize some of the main ideas. It forces you to think about the process and the methodology. And then you review the comments back, and you really learn, it's invaluable to go through those comments, because that's what really brings you to the next level. I think it's that process. So I think it's working through the process. So as Joe alluded to, collecting the data, writing the paper, but I think the grant writing process was really critical for me as well. So, but to get back to your question in terms of the main obstacle, and I know we're running out of time, I'm not sure that I can put it down to one thing. I think having a methodologist in terms of clinical research, some of the things that have really helped, having a methodologist help out along in terms of the bigger trials early on is critical. Yep. Data collection is only robust insofar as you've got a research coordinator that you can trust who's really invested in it. Having a statistician help with the analyses in the bigger trials, I think, is also critical. So these are some of the things. It's funny, you know, the comment about blocks of time. I've always taken a day of research a week out of my schedule, and I've really found that to be helpful as well. I mean, it's not to say that we aren't all running 2 full-time jobs and working at these things in the evenings and weekends as well. Of course, that's also part of it, and we're happy to do that. But I do find that taking some time during the week is also helpful. Very quickly, the last question in terms of how to get residents and fellows involved and whether the system here is any different. I don't think it is. I think it's a cultural thing. And in our program, the residents have to complete 2 projects and present them at our research day before their 4th year of residency. So I think instituting that sort of we basically, there's no choice, they have to do it. And so they tend to gravitate toward the clinician investigators and scientists. And I think that way we maintain the level at a fairly, hopefully high standard.
Okay. Great. Those are tremendous kind of insight into what you're doing. And also, hopefully it will help the people that are on to honestly think about starting some of this work themselves. And I think that's really been the goal of this group of webinars, is to not necessarily give all the answers, but maybe hopefully to incite people to go out and do better research. And, you know, Ty and I, we kind of talked about this, and this came from the grants that we were reviewing for the ASCS. And one of the ideas was, okay, how do we get better grants? And one of the ways we thought might be, okay, well, let's try to teach people better ways to do research. And so hopefully the people that were on tonight were able to gain a lot from this. I know I did. And hopefully they'll join us for the next 2 sessions as well. I want to thank everyone that participated. John, Joe, Peter, great. This was right on mark of what we were hoping for. Ty and I would like to thank you and also the ASCS for giving us an opportunity to be able to present this. Otherwise, I think tonight we're good, and I appreciate all the participants that came on. And otherwise, everyone have a good evening.
Great, thank you.
Thank you so much.
For the opportunity.
Great job, guys. Thank you.